So if we take those concepts of local, segmental, supraspinal, and we apply them to other structures in the body. So if we think about how this relates purely to segmental analgesia. So when we're talking about segments, and this confuses some people sometimes, we're not only talking about the spinal segment, but we're also talking about the nerve root that comes away from that and what that innervates. So we're talking about dermatomes, myotomes, sclerotomes, and also viscerotomes as well. So skin, muscle, bone, connective tissue, and organ systems as well. And the innervation of these structures ties back to certain spinal segments, as we know. And dysfunctions at that segment can affect peripheral problems and vice versa. So we can have a two-way communication between what's going on peripherally and what's going on more centrally. And this can lead us to pathologies that we're well aware of, like radiculopathies and so on, but it can also lead us to other dysfunctions as well. So it isn't always about that referred pain or that change of sensation. It can be about other things as well. And this we can see particularly when we look at things like organ responses and viscerotomal responses. And so the idea of using needling to deal with things like digestive issues or bladder issues can be a little bit alien to some people. But if we think about sort of standard approaches that have been used, if we look at things like the treatment of overactive bladder with PTNS, posterior tibial nerve stimulation, or percutaneous tibial nerve stimulation, the insertion of a needle 1 hand's breadth above the medial malleolus and posterior to the tibia in that location. And if we think about where that needle's been inserted into, it's been inserted into flexor lucis or flexor digitorum longus, posterior sort of tibial position. And we can also insert a needle then into the separation or the muscular tendinous junction separation between the heads of gastrocs down into soleus. And we could connect those 2 points up, and we could run electrical stimulus through those, so have E-stim through those, or alternatively we can have the needle in 1 hand's breadth above the medial malleolus posterior to the tibia, and then one inferior to the medial malleolus, and connect those 2 up instead. And what's the relevance of that to this? Well, those approaches are referred to as PTNS, percutaneous tibial nerve stimulation, or alternatively posterior tibial nerve stimulation. And so those muscular structures that I mentioned are innervated by the posterior tibial nerve, which when it tracks back to its spinal root goes back to S2. And you might be thinking, well, what's that got to do with any of this? You know, are we treating leg pain? Is it radiculopathy? But the interesting thing about S2 is that's the parasympathetic innervation to the bladder. And so creating an afferent input that's ascending to the spinal cord and the reflective response to the parasympathetic reaction that is actually returning from that and stimulating the bladder at that region. As I said, S2 is the parasympathetic innervation to the bladder. It can affect overactive or sympathetic bladder responses. So we can reduce down that overactivity of the bladder, and that's been shown in numerous studies to be beneficial. It may also be the case that that will affect bowel function as well, because if you think about that S2 parasympathetic innervation, it's also going to innervate the bowel, it will also innervate external genitalia, and it will also innervate the uterus to some degree as well, which can be influential when treating certain symptoms in female patients. So that's our parasympathetic innervation. We've also got a sympathetic innervation as well. Now that lies at L2. So the needling of L2 and S2 can be very useful for bowel and bladder dysfunctions in numerous ways. And that can be influential again when we're looking at healing and recovery with athletes. Because if there's issues with absorption or expulsion of waste products within the body, that can have a negative effect on recovery and performance as well. You know, these functions are integral to normal homeostatic balance. And remember, when we talk about homeostasis, that's the path of least resistance for all living organisms, whether it's in a cell or we're moving up to multiple cells into a structure or an organ system or an entire body with 10 trillion cells. You know, the interrelationship of that cellular activity is very, very important, and that's what it comes down to. So homeostasis is an integral component, because if we don't have a baseline for healing and recovery, we're going to have issues. So if we've got an underlying pathology that's dysfunctional, that's going to affect our ability to build on that. And so things like bowel and bladder function can be integral, not can be, but are integral to not only healing and recovery, but also elevating above that to performance. And so the utilisation of a viscerotomal response can be significant. So just entertain that idea going forward. And as we can see, this interrelationship between different spinal segments and different visceral structures can be of use to us to understand how we can perhaps influence that to a greater or lesser degree. Two things that we can't change, particularly when we're working in physical medicine, that's physics and physiology. So it's useful to understand how these play together, shall we say. So when we're looking at rehabilitation, we're thinking very much about the physics of rehabilitation, this sort of exercise in this position, this joint angle, this movement, the biomechanics in this. And we spend a lot of time, we're quite happy with those ideas, and we think that's a very structured way to work with our performance and so on. But we've also got to be thinking about physiology, and that's not just the realm of exercise physiologists, because that ties very much in with healing. And where we're going from healing to increased performance sits on the same continuum. There isn't a place here and here that we need to jump between. There isn't a difference between healing and recovery and performance. They're on the same spectrum. There's not a chasm that we need to cross here. What we need to consider is they're both integral to each other, and it's a sliding spectrum. And your athlete will be anywhere on that spectrum. And what you need to do is to facilitate the process in the right direction. So how do you get from A to B? And what's the quickest route, and what's the most effective route, and what's going to stop you dropping back? So it's thinking about those things and what we can do to enhance. So understanding the physiology is important, the physics and the physiology. So when we're clinical reasoning, what do we need to do? What do we need to put together? Well, what we need to consider first of all is what's the pathophysiology of the problem? What's presenting? When I'm asked to mentor or advise other clinicians, they'll come to me and they say, well, can I use needling for this? Well, I could give a very simple answer. The answer would be yes. The answer is pretty much always yes. If you're treating any pain, any soft tissue dysfunction, anything that's a deviation from homeostasis, the answer in theory is yes. And when we talk about deviation in homeostasis, remember that all conditions are a deviation in homeostasis, and all diseases are soft tissue problems, and everything is systemic. So it's a very broad answer, but that's not really the question that people are asking. The question that people are actually asking, or should be asking, shall we say, is this the most effective modality in this patient, at this time, with this pathology, in this environment, at this stage of healing or recovery? And the answer to that might be very, very different, because the answer to that may be no. This isn't about putting needles in people, and the goal is not to put needles in people. The goal is to improve the outcomes, to get them better, and is to improve their performance, is to get to where we need to be. The goal isn't to put needles in people, but if putting needles in people is going to allow us to get further along that line, further along that journey in that process in a more efficient and effective way, then yes, that's what we need to do. But we always need to think about, okay, if needling is going to work, how is it going to work? It's not magic, it's got a certain physiological effect. So when we're thinking about this, we need to consider, well, what's the pathophysiology? So when guys come to me and say, well, can I use it on this condition? I'll say, well, hold on a minute, how does this position present? What's this presenting condition? Tell me about the N equals 1. Okay? What do we see here? Tell me about this individual. Tell me about this athlete. Rather than saying, oh, can I use this on anterior knee pain? Yes, fine. That's not the answer you're looking for. The answer is, okay, tell me about this pain. How does it present? What does this individual do? When does it present? We start to break things down. And then we can start to differentially diagnose. And if we can differentially diagnose the problem, we can have a better idea of how to treat it. And then we can think about the pathophysiology, because that's got to verse the mechanisms of needling. Because if you want needling to have an effect, how do you propose it's going to have an effect, rather than just putting it in? What we don't want to get into is this idea that I've tried everything else, I think I'll try some needling. Because that's not clinical reasoning. That's, I haven't got anything else to do, I'll try this. It's a Hail Mary. at the end of the day. Now, in some cases it may work, and Hail Marys do work, but they fail more times than they work. We just remember the ones that work because we never expected them to work. That's why it's a Hail Mary. And I suppose when we look at that, we've got to consider, well, why do we think this would work? If everything else failed before this, what was it about this that we thought would make it work? We don't want to hang too much on that. We want to be thinking why. And so we think about the mechanisms. But if we're applying that, we've also got to think about, okay, what's going on with this individual? We need a multimodal approach. So we're thinking about exercise, we're thinking about needling, we're thinking about advice, manual therapy, any other intervention that we want to bring in, because it's a multifactorial problem, because everyone's problems are multifactorial, and therefore it's going to need a multimodal approach. If it's a mechanical problem, it's going to require mechanical resolution. So how do we achieve that mechanical resolution? We need to think about these things. So when we think about those mechanisms, what have we got? We've got local effects, we've got segmental effects, we've got distal and perineural responses that we can have. We've got paraspinal needling, which can be very useful, both superficial and deep from an analgesic, but also mechanical perspective as well. So again, depending on what we do with the needle, determines whether this is purely a mechanical or a physiological response. And even if we're looking at a mechanical reaction, we'll always have a physiological reaction as well, because we're inserting a needle into somebody. And we can think about simple things like trigger points. Is this a myofascial issue? Do I need to go local to the tissue? Do I need to go spinal for the trigger point as well? And we think about how that fits together. And then other techniques. Do I need to go local to the tissue? Am I creating just a purely physiological response? Am I surrounding the dragon, or am I using an eagle claw technique, or am I using like a Stonehenge or a matrix? And I'll talk about these interventions and these techniques and what we're trying to achieve with these later on. TCA. This is about entertaining an idea. You'll find some elements that will occur in more traditional approaches, traditional acupuncture approaches. And what we can do is we can take them for what they are. We can look at them, we can pull them out of that system, and we can put them down in front of us and we can examine them and think, okay, if you're suggesting that this has a certain level of beneficial effect, why? What's the mechanism? Because it's not magic. So if you're proposing it has an effect, how does it have an effect? And I'm not talking about more kind of sandals and candles approaches like yin and yang and zhang fu and those sorts of ideas. I'm talking about what is actually happening down there in the tissue when you're putting that needle in. What's the approach? What's the outcome? What are we getting out of that? And one of the useful things about needling as well is needling can be diagnostic. So we're putting that needle in and it can tell us different things. If it changes up that condition, if we think that problem's a spinal radiculopathic problem, but once we start to needle into the spine, or we start to needle into the lower back and around the pelvis, and we see a change in those peripheral symptoms, we've got to ask ourselves, okay, well, is that the pathology we thought it was? Because if you take a very chronic pathology, like a tendinopathy, and you needle it, and it's gone within 1 or 2 treatments, well, I think you've got to consider either acupuncture's magic, or that's not the pathology you thought it was. I'd like it to be the former. It's actually going to be the latter, that there is no magic, it's just physiological response, and it's keeping your mind on that track to understand that. So that comes into this. Although we might talk about traditional Chinese acupuncture as a concept, we can look at it from outside. We don't have to get into it. We can look at it from outside. We can take some of these things that we'll see in the literature, and I'm not necessarily talking about historic literature, I'm talking about papers being published now. And we can take those interventions, pull them out and go, okay, well, what anatomical structure is this needle in? Okay, and what is it innervated by? Or what is it adjacent to? Why do we think that doing that will have a physiological effect? Or is it something different? Is it more of a placebo or psychological effect? How do we evaluate this? And can it be of benefit to us to solve a problem? Perhaps it can, because it's observational consensus medicine. Let's keep that to one side, but consider it. Always entertain an idea, because there's things to learn if you do. And then when we put these ideas together and we put them through the funnel, and what we get on the outside of that comes to the application. And now we've always got to respect the patient, respect the anatomy, respect the technique. What we don't want to do is lose sight of any of these. We don't want any of these things to get in the way and start changing what happens here. And this is where our clinical reasoning comes out, informed by our differential diagnosis and our clear thought process based on best available external evidence as well, which can be made up from bench and bedside trials. So bench and bedside, bench is lab trials, bedside are clinical trials. But if we haven't got enough clinical trials in a certain subject area where we're working, we can draw inference from other trials, or we can look at physiological mechanisms and use those to influence us as well. And then we've got our clinical experience, which fits in around here, but also patient preference. There's no point reinventing the wheel. Somebody comes to you and they're talking about an intervention that they've had, it's worth exploring that intervention. But also if somebody comes to me and they tell me that they've had a needling intervention before and it didn't work, I don't dismiss the idea of using that again. I try to ascertain, okay, so what sort of intervention did they use? Because saying that you've had needling before it didn't work is like saying, I've had exercise before it didn't work, or I've taken tablets before they didn't work. It's that broad. And when you work in the world of exercise, if someone wants to say to you, I've tried exercise before it didn't work, would you dismiss the idea of exercise? Of course you wouldn't. What you've got to ascertain is, what was the problem? What sort of exercise? What was the prescription? How, when, where, why, what? How was it? How did it fit together? And for me, exactly the same with needling. If you've got a strong background in manual therapy, it should be exactly the same. Just because someone's had manual therapy before doesn't mean they're not going to have it again. So this all informs this clinical reasoning process. And then we have the application. And then we reason all over again when we bring that application in and see what we get. So it's always an organic, continuous process of understanding. But if we miss out any of these ideas or factors, we can find that we're missing integral points for our reasoning. And of course, we put this through our subjective and objective filter to make sure that it's appropriate for what we're doing.